There is a STAR trial going on in Zambia. This is separate to that. So this is a 3IE funded study. It's a different model of distribution of self-tests, so I'll describe that. And it's also in different settings. And when I was asked to give this talk, I was asked to talk about how we're evaluating impact in this study. So I'm going to be mostly talking about that after a bit of an introduction. So just to give you an outline, first I'll talk about the background. So as Liz mentioned, this is nested within PopART, so I'll talk a bit about that. I'll talk about the rationale for nesting a pilot HIV self-testing study within PopART, talk about the distribution model, and then go on to talk about how we're using routine data collected through the intervention to evaluate the impact of this study. So I think most of you have probably heard of PopART, or HPTN 071. It's a community-based randomized trial to evaluate the impact of a household-based approach to combination HIV prevention on the impact of HIV incidence in both Zambia and South Africa. And in the intervention settings, community healthcare workers, which we refer to as CHIPs, community HIV care providers, go door-to-door offering HIV testing services, but also provide linkage to care services. So for individuals who test HIV positive, they link them to the facility for ART. For men testing HIV negative, refer them to VMMC. And they also do a lot of condom promotion and condom distribution. And the CHIPs, they go door to door and they enumerate households. And the people that they meet are asked for their consent to have the PopART intervention explained to them, and then are offered these various HIV-related services. And so as the CHIPs go door to door, they have what I'm going to be referring to as an EDC. So this is an electronic data capture device, and they use this as they're going to each household. And as I alluded to, what they do is they enumerate the household. So this EDC has information on the household members in each household in the community, whether that person was absent or present during the CHIPs visit, the age of that individual, whether they're male or female, and so on. And for individuals that the CHIP actually sees, there's also information about what interventions that individual accepted. So for example, if they chose to take an HIV test, that's logged in the EDC, and also the result of that test, and so on. So to date, and I'm going to be talking here about only Zambia, so as I mentioned, PopART is being done in South Africa as well, but I'm only talking about Zambia here. So this EDC data has been used already to date to measure coverage of intervention components and also progress towards the 1990 targets in the PopART communities. And I don't want to dwell on this too much. This has all been presented at CROI, so I encourage you to look up the references if you can read them. So in Zambia, for example, at the end of annual round 1, 83% of the individual adults that were enumerated consented to participate. And of those who did not self-report that they were HIV positive, 71% accepted an offer of HIV testing from the CHIP. After annual round 2, thinking about the 1990s, about 78% of men and 90% of women were aware of their HIV positive status. So that is about 86% overall. So the reason why I put this up here is to show that PopART has made great successes, obviously. But nonetheless, and as we've been hearing in these last 2 days, there's definitely been some challenges in reaching certain populations. And you're probably not surprised to see men up there, because when the CHIPs go door to door, it's often during the day and they don't find the men at home. In addition, adolescents and young people are less likely to accept HIV testing services, so that's also been a population that's been trickier to reach through this door-to-door strategy. So that leads on to the rationale for HIV self-testing. So not only in Zambia, but in other settings, the door-to-door offer of HIV testing services hasn't reached all populations. So the hypothesis was that providing individuals with a menu of options for how to test for HIV when someone comes to their door could encourage increased uptake of HIV testing services and thereby increase knowledge of HIV status. And we also thought, thinking about men who aren't at home, maybe leaving a test kit for their partner who is there could help reach those men who we aren't finding at the moment. So we saw PopART really as an opportunity to test this hypothesis and to use an existing structure, so an infrastructure of community healthcare workers and a data collection structure to test this hypothesis. And so that's what we're doing in this study. And I'm sure you can't see this graphic, but it shows you basically in the zones where the pilot intervention is being done, what the chips can do. So now, in these zones that have been randomized to the self-testing intervention, the chips, as they go door to door, for people who are accepting an offer of HIV testing, they can now offer them a finger prick or an HIV self-test. And if the person chooses an HIV self-test, they have a number of other options around how they actually do that test. So do they want to do it in the presence of the chip, but have the chip not observe the process, or do they want to do it once the chip is left and do it without any observation? And just to say that the test kits are, if the chip sees the individual, the test kit is only being left for people who are aged 16 years and above. But as I said, men have been an issue, and we'd like to reach men through this strategy. So for an individual who's 18 years or above, so primarily obviously the females, if they have a partner or spouse who's absent at the time of the chip's visit, they're offered if they'd want to take an HIV self-test on behalf of their absent partner. So this is just a schematic to show you how the impact evaluation is going to be done. So I've described the intervention. Now I'm going to tell you how we're actually evaluating whether this intervention worked. So this schematic just shows you that the intervention is being done in 4 PopART intervention communities. Within these 4 communities, there are 66 zones, and these have been randomized to either in blue, the pilot self-testing intervention, or in green, the standard PopART intervention. So the chips going door to door, but not offering HIV self-testing. And what I want to draw your attention to is the arrow on your right. So that just shows you that the data that we have. So before this intervention started, there was the CHIPS data as they were going door to door, and that's the data that we'll be using to evaluate the intervention, and that data is collected in both sites where the CHIPS, because the CHIPS are operational in all these zones. So this is just a map of Zambia. You can see the triangles, hopefully. Those show you the PopART intervention sites. The PopART study sites. And then the triangles with the squares around it are the HIV self-testing intervention sites. And then the boxes around it, which I don't think you can see on this slide, but in blue, those are the zones that have been randomized to the HIV self-testing intervention. So our primary outcome, what we hope to achieve through this intervention, is that more people will be aware of their HIV status. And our definition of knowledge of HIV status is either that an individual has told the chip that they're HIV positive, or they've accepted an offer of HIV testing. So we hope, obviously, that we'll see an increase of knowledge of HIV status in our self-testing communities. And as I'm sure you've realized, the data we're going to use to evaluate this is the data routinely collected as part of the PopART intervention, so the EDC data, the data from the CHIPS EDC. So in the zones where the HIV self-testing is being done, those blue zones I showed you, the CHIPS EDC has been modified to allow them to collect data specifically to HIV self-testing. So it allows them to collect data on whether the individuals opted for self-testing, and then if they have opted for self-testing, what kind of testing they've opted for, whether it was supervised or unsupervised, and so on. And it also allows the chip to record whether someone took an HIV self-test for their absent partner, and also whether that self-test was ultimately used, because the chip will go back to the households where they left a self-test kit to follow up on what happened with that test kit. So it is quite, as Melissa alluded to with STAR as well, there's a lot of data that's collected as part of this intervention. And so we're going to be using this EDC data to estimate whether the intervention worked, so whether it actually increased knowledge of HIV status. And I just put here just briefly, but I won't explain exactly how, but the data that we'll be using is, I talked about that the data also has enumeration of households. So we're going to be using data on what population was actually seen during that, or enumerated during the period of the HIV self-testing intervention. It's actually a very short pilot, so on this title page, I don't know if you saw it, it's a pilot intervention. So it's actually quite a short intervention. So who did they see, who did the chip see during that period of the intervention? And then also using data on who self-reported HIV positive. As I mentioned, that's part of our definition of our outcome. who took an HIV self-test, and also who the CHIP actually saw, who the CHIP saw and consented to PopART and accepted an offer of HIV testing. We have, of course, a number of secondary outcomes that we want to look at. The first one is to look at, well, we thought that maybe having self-testing in the community, people might be more likely to consent to the overall PopART study, so having that study explained to them. And of course, we thought that amongst the people that the CHIP actually sees, because remember, the primary outcome includes a population denominator, so all the study population that's been enumerated. But amongst those people that the CHIP actually sees, is there an increase in uptake of HIV testing services? And there's a number of other secondary outcomes, but I haven't put them up here. And then, of course, as I mentioned early on, the motivation for this really was to try and reach those who aren't being reached. So we'll be looking at these outcomes amongst men, of course, amongst adolescents and young people, particularly aged 16 to 29, but also individuals who recently moved into the community, but also individuals who the CHIP has seen or has never seen and haven't accepted an offer of HIV testing. And my colleague recently defined these as the persistent refusers. And Melissa nicely laid out how in STAR they're measuring inputs, outputs, and so on. So I also just wanted to highlight that we too, as part of this 3IE study, are looking at what is the process of this intervention. So we're of course interested in the impact, but how is the test used? So do most people want supervised or unsupervised testing? If someone takes a test kit for their partner, does the partner actually use the test kit, for example? So how do people engage with the intervention? And then you can't see it on this schematic, unfortunately, but this is kind of our hypothesized pathway of how we think the intervention ultimately leads to our primary outcome. And it's color-coded to show you that in the letters in black are what will be collected is data that will also emerge from the CHIPS EDC. But then we also have a very strong social science team collecting qualitative data to look at acceptability of the strategy of HIV self-testing itself, any social harms that are emerging, and so on. And also whether there's any burden on the CHIPS of delivering self-testing as part of their package of services that they offer door to door. So just in summary, I think we all know that there remains a need for alternate strategies to deliver HIV testing services. Even in the door-to-door strategy that we've seen in Zambia, it's been very successful through PopART, but there remains some harder to reach populations. And so we've hypothesized that when going door-to-door, if you offer people a menu of options for how to test, that might encourage them to test more and ultimately lead to more people knowing their HIV status. So as I've mentioned, we're doing a pilot of this in an existing study. We're taking advantage of an existing structure of CHIPS and data collection structure. And as I mentioned as well, the impact will be evaluated through data that's routinely collected by the CHIPS as they deliver this intervention. It is quite data heavy, the amount of data they collect, but it's a valuable resource for us to see, well, does this strategy work? And as you'll notice, I haven't presented any results yet. And I also said that it's quite a short study, so we hope to have results by the middle of the year. So if not, maybe sooner, so do keep an eye out for our results. And as a last point, I just want to acknowledge the study team. So Alwyn Mwinga and Helen Ailes are in the audience. They're both PIs in the study. And particularly Chama Mulubwa, who's the study manager. And of course, the Zambian Ministry of Health and 3IE and the whole study, PopART study team. Thank you.